I'll call to order the meeting of Commerce and Labor for this Friday, May 12th. Good morning and welcome. Madam Secretary, please call the roll.
Senator Buck, Senator Daley, Senator Hammond, Senator Lang, Senator Pizzina, Senator Scheibel, Senator Stone, Chair Spearman.
Please mark Chair Spearman absent and excused. And on the other members, as they arrive, please mark them present. I know some are presenting in other committees. So thank you. Today we're going to hear AB 120 and AB 198. Just want to remind everyone it's morning time. We've all been looking at our phones and checking what happened overnight. And so make sure those are silent so they don't go off during the meeting. If you're going to give public testimony, make sure you've signed in on the table right over there on the clipboard. Provided a business card to our secretaries so that they can do the work that they need to do. With that, let's get right into our agenda. I will now open the hearing on Assembly Bill 120, sponsored by Assemblyman Hafen. Ooh, there he is. The measure revises provisions related to industrial insurance, revises certain provisions governing voluntary health care service. And please proceed when you're ready.
Good morning, Vice Chair Lang, Senators. It's wonderful to be in here. I think this is my first time presenting in front of you, so I'm very excited to see everyone. My name is Assemblyman Gregory Hafen II. I represent Assembly District 36, and I am the sponsor of Assembly Bill 120. Existing law under NRS 629450 currently prohibits healthcare providers who have not actively practiced their profession continuously for the immediate preceding 3 years from volunteering their healthcare services and associated with a sponsored organization, such as the Remote Area Medical Program. This statute prohibits volunteers and specifically recent graduates of healthcare from providing essential medical, dental, vision, and other service to the underserved areas, especially in rural Nevada. And I want to hit hard on this recent graduate. So if you're a student at UNLV Dental or Medical School, you can volunteer your time. As soon as you graduate, you are no longer allowed to volunteer your time for 3 years. And so that is the intent of this bill, is to try to allow the recent graduates that can work, they can hang a shingle and go to work, but they can no longer volunteer. And so I want to also, Vice Chair Lang, with your permission, kind of give an example and some background information. Thank you. So this prohibition has negatively impacted healthcare services in rural Nevada, and we had a UNLV dental provider who was a volunteer for the RAM program as a dental student, came back upon graduation and wanted to continue their volunteer service, but could not any longer because of this provision under existing law. And the Department of Health and Human Services had to decline the volunteer services. So as noted earlier, residents throughout Nevada, especially in rural Nevada, benefit extremely from these free pop-up clinics. In both Pahrump and Tonopah recently, we've had these pop-up clinics come to the communities and provide services. And a few years back, RAM came into Pahrump and provided dental services to a lady who was in kidney failure. And before the hospitals could do a transplant for her, she had to have multiple teeth removed. She was able to use the RAM facility and the pop-up clinic to have her teeth removed and then proceed forward with the transplant. Had we not had these volunteer healthcare workers, I don't know that she would have ever been able to afford to have her teeth removed and be able to proceed with the procedure. So I just want to touch on the bill itself, subsection 2C of section 1, it's very short. It just to amend the restriction that a provider of health care who has not actively practiced his or her profession continuously for the immediately preceding 3 years from providing healthcare services. By removing this restriction, it'll ultimately allow qualified healthcare providers, specifically recent graduates, to continue their volunteer service in association with sponsored organizations. And with these volunteers, Nevada residents, especially the poorest of our communities, have an opportunity to receive the care that they desperately need in order to live a healthier life. And today, I believe on Zoom, I have Ryan Muccio, who is the director over at Inspirations Senior Living in Pahrump, Stacy Smith, the CEO of Nye Community Coalitions, Chris Hall, the CEO of RAM, and in the audience, we do have Mr. Kyle Devine, the Deputy Administrator for DHHS, if there are any questions.
Thank you, Assemblyman, and we'll go ahead and take questions from the committee. Are there any questions? Senator Scheibel.
Thank you so much, and thank you for your presentation. I like this bill, and I like this concept, and maybe it's just because it's so early in the morning. I'm trying to understand the significance of the 3-year timeline. Is it related to their length of residency, or is it just a number that, you know, you talked to stakeholders about and made sense? Why 3 years?
Madam Vice Chair, through you to Senator Scheibel.
Please just go direct.
Thank you. Assemblyman Gregory Hafen for the record. That is a great question. I have spent the last 4.5 years trying to get an answer to why in statute we currently have that restriction. I have not been able to receive an answer of why that is. And so I've had some conversations with previous legislators that there was a concern way back when with the retirees that once they retired, if they're 10 years out from practicing and they're not keeping their, continuing educations up, that maybe they shouldn't be practicing and volunteering. And so we're not changing that portion, so the retirees after the 3 years would no longer, but we're trying to address the recent graduates. This is the cream of the crop. I mean, we're investing hundreds of millions of dollars into our medical schools throughout the state, and our dental schools, and so we want these individuals, and if they're volunteering currently, we want to keep them volunteering, especially here in this state where we have a desperate shortage of medical professionals.
I totally agree, so thank you. Thank you, Madam Chair.
You're welcome. Any other questions? Seeing none, if you want to step back, we'll take public comment. Anyone wishing to speak in support of Assembly Bill 120, please come to the front. I'm sorry. In education, people are so used to just going ahead, so please just go ahead.
Thank you, Madam Chair. Committee, for the record, Susan Fisher with McDonald Corano speaking this morning on behalf of the Nevada State Board of Osteopathic Medicine. We fully support AB 120. We thank Assemblyman Hafen for bringing this bill. This just corrects a nonsensical omission, we think, in law, and to allow these volunteers to go ahead and practice. Thank you.
Thank you. Next person, please.
Good morning, Madam Vice Chair and members of the committee. So a little history. And I'm here. I'm Sarah Adler here as myself. And many years ago, I joined the board of the Healthy Communities Coalition of Lyon and Story County. And this guy, Ernie Adler, was available to us, and he drafted the original language to create access to volunteer healthcare professionals, and Tom Grady was the assemblyman at the time, and he carried the bill. So I have a personal connection to this, and I can also share with you, with respect to the sponsor, when he refers to RAM, Remote Area Medical, as a pop-up clinic, it is a clinic that comes to a community after months of planning, bring semis of equipment really gets into both dental and vision care when they have the opportunity to have those professionals, volunteer professionals, as well as healthcare. Ernie is a Rotary member. There's a Rotary guy who invented a dental sink without being connected to pipes that they use. So these are very sophisticated provisions of healthcare to people who desperately need it. I have attended them in Silver Spring, supported them many times with my ability to help people fill out paper, no other healthcare ability. And literally, we have all been brought to tears by the difference that these clinics have made. So, as Sarah Adler, Healthy Communities Coalition board member, urge your support. Thank you.
Thanks so much. Please go ahead.
Thank you, Madam Vice Chair. Good morning, members of the committee. Blaine Osborne, Nevada Rural Hospital Partners. Happy to be here in support of AB 120. Thank you.
Next, my microphone's not working.
Thank you, Madam Vice Chair, members of the committee. For the record, my name is Paige Barnes with the Ferrado Company here today on behalf of the Nevada Nurses Association. We think that this bill is sort of one tool in our tool belt to help bring more providers to Nevada patients, including our most rural communities. Thank you.
Thank you. Please go ahead.
Good morning, Madam Chair and members of the committee. My name is Mary Nakashima Nielsen, here on behalf of the Nevada State Medical Association, and we're here in support of AB 120 and want to thank the sponsor for his work on this bill.
Thank you. And I see we have one person in Las Vegas.
Thank you, Madam Chair and members of the committee, and good morning. For the record, my name is Trevor Parrish, and I'm here on behalf of the Vegas Chamber. The Chamber is in support of AB 120, as we believe this bill will be another important tool to help address our doctor shortage here in Nevada. Also, this bill will help assist in providing services to medically underrepresented communities. We urge your support of AB 120, and thank you for your time.
Thank you. BPS, is there anyone on the phone lines?
If you would like to testify in support of AB 120, please press star 9 now to take your place in the queue. The public line is open and working. There are no callers at this time.
Thank you. Anyone in Carson City wishing to speak in opposition? Seeing no one in Carson City, there's no one in Las Vegas. Is there anyone on the phone lines?
If you would like to testify in opposition to AB 120, please press star 9 now to take your place in the queue or raise your hand in the Zoom window. The public line is open and working. There are no callers at this time.
Okay, thank you. Is there anyone wishing to speak in neutral in Las Vegas, Carson City, and on the phone lines?
If you would like to testify in neutral for AB 120, please press star 9 now to take your place in the queue or raise your hand in the Zoom window.
Wiz Rizard, W-I-Z-R-O-U-Z-A-R-D, Deputy State Director with Americans for Prosperity here in Nevada. I was actually attempting to testify in support of AB 120, and if it pleases the chair, I'd like to have the testimony moved out of support and in due respect to time. Just want to say ditto to everyone's statement, and we greatly appreciate Assemblyman Greg Hafen for carrying this bill and really giving Nevadan doctors the ability to contribute to their community. Thank you.
Thank you so much. BPS, is there anyone on the lines wishing to speak in neutral?
There are no callers choosing to testify at this time.
Thank you. Assemblyman Hafen.
Thank you, Madam Vice Chair. And if I may, would like to touch on what Mrs. Adler said, because I did not explain the process very well of how it currently works. So currently, these organizations like RAM will go through DHHS. They spend months getting everybody fully vetted and making sure that they're fully licensed and that the proper insurance and everything else is in place. And As Mrs. Adler stated, these aren't just like a tent in somebody's backyard. These are semi-trucks that are brought in and come from all over the country and come throughout rural Nevada. And our most recent one in Pahrump, they took over the entire high school and set up clinics in every room and had different stations throughout for different services. So it's very well organized, providing desperately needed services throughout our state. And I want to thank you and thank the committee for your time this morning. I know it's early on a Friday, and I'm sure everybody's ready to go, but I'm very appreciative of it. Thank you.
You're the most important person here right now, so thank you so much for being here. And with that, we'll close the hearing on Assembly Bill 120, and I'll open the hearing on Assembly Bill 198. This Assemblyman Orrin Lecter. This measure revises provisions governing health care. And when you're ready, please proceed.
Okay. Thank you, Vice Chair. And
Assemblyman Orrin Lecter, could we take a 1-minute recess, and will you come up here for a minute? Okay, I'll call the committee back to order, and Assemblyman, you may begin when you're ready.
thank you, Vice Chair and members of the Commerce and Labor Committee. Good morning. David Orientlicker, Assemblyman from District 20 in Southeast Las Vegas. And I'm joined by a number of co-presenters, Art Savanack and Miranda Hoover, and possibly Paul Young, but maybe not. We'll see. And the goal of this is to address the one element in the shortage of healthcare professionals in Nevada, and specifically with nurse anesthetists. Under current law, they're not able to practice within their full scope of authority. What they're trained to do, what they're capable of doing, our current law doesn't allow them to practice. And this is a particular concern in rural areas, because while in Reno and Las Vegas, nurse anesthetists and anesthesiologists practice together as a team, when you get to some of the rural hospitals, as you'll hear during the testimony, there aren't any anesthesiologists. So if you don't have a nurse anesthetist delivering anesthesia services, you don't do the procedures. And so that's why we have this proposal in AB 198. And I'll turn it over to my co-presenters to go into more depth about the problems with our current statutes and how that affects delivery of anesthesia services.
Thank you. Miranda Hoover for the record. Good morning, Vice Chair Lang and members of the committee. I'm here today co-representing all certified registered nurse anesthetists who practice in the state of Nevada, here with my colleague, the chair of the Nevada Association of Nurse Anesthetists, who I will introduce momentarily. Certified registered nurse anesthetists, or CRNAs, as I will refer to them as going forward, have been passionately and safely providing care to patients for more than 150 years in the United States. CRNAs are educated and trained to work without physician supervision and to exercise independent judgment, especially when having to respond quickly to emergencies. AB 198 brings merit to the highly educated and trained licensed professionals that CRNAs are and will help Nevada to attract additional CRNAs, which in turn will work to combat our anesthesia provider shortage. With that, I will dive into the language of the bill. Sections 2 and 3 codifies language that has been in practice and part of the CRNA scope for their entire history. This bill allows CRNAs to continue providing safe care in all settings where they are licensed to practice and simply defines their service capability in statute for services which they have been providing since the Civil War. CRNAs will continue to be licensed and regulated under the Board of Nursing and will also now be required by the Board of Pharmacy to pay an additional annual $300 fee as CRNAs are being added to their definition of practitioner so that the law clearly reads that CRNAs can order, prescribe, possess, and administer controlled substances, poisons, dangerous drugs, and devices to treat a patient under the care of a licensed physician, a licensed dentist, or a licensed podiatric physician. CRNAs are qualified to make independent judgments regarding all aspects of anesthesia care based on their education, licensure, and certification. CRNAs practice with a high degree of autonomy and are comfortable doing so because graduates of nurse anesthesia programs have an average of 9,369 hours or 390 straight 24-hour days of clinical experience. The remainder of this bill cleans up language to bring this chapter into conformity with the change of including CRNAs into the prescribing chapters. CRNAs over the last couple of years have run into issues in Nevada, not being able to successfully administer care because this language has not been codified in statute. Their scope is currently only spelt out in the NAC. The intention here is to simply add prescriptive authority to the scope of practice language that CRNAs have currently in the NAC and codify it into modern law so they can continue providing quality patient care in Nevada. This will alleviate the question from regulatory entities about A, who has jurisdiction over CRNAs, and B, to ensure CRNAs can continue providing safe care throughout the entire state. With that, I'm going to pass the rest of the bill presentation over to my colleague, Art Savignac, the chair of the Nevada Association of Nurse Anesthetists. Thank you.
Arthur Savignac, for the record. I am the president of the Nevada Association of Nurse Anesthetists. Madam Chair and panel, thank you for allowing me the opportunity to speak today. As a representative of 125 nurse anesthetists in the state of Nevada who provide anesthesia care both in the cities and in the rural areas of this state, thank you. And we would like our message to be heard as far as anesthesia practice goes in this state. We provide anesthesia care 24/7, 365 in operating rooms, obstetric suites, MRIs, offices, dental offices, plastic surgery clinics, emergency rooms, over the vast majorities of the facilities in this state, provided safely and daily. And we appreciate you hearing our message on this today. A little background about myself. I have been a CRNA for 33 years. I've been a nurse for 40 years. Of those 33 years, I spent in the United States Army for 15 years, retired as a lieutenant colonel, and provided anesthesia care around the world for soldiers and their families, proudly and well. Of those times, I had multiple assignments within the United States Army, one of them at Fort Bragg. At Fort Bragg for 2 years, I was a member of Joint Special Operations Command, where we provided anesthesia care to special operations warriors around the world. We had a 1-hour callback requirement. We had the ability or the necessity to be available 24/7 to provide anesthesia care in a forward environment to take care of soldiers who have been critically injured, providing trauma and resuscitative care to these soldiers. CRNAs were chosen primarily because A, we were excellent anesthesia providers, but B, as critical care nurses, we had the requisite experience to take care of soldiers who have been wounded in the absence of the ability to medically evacuate these patients back to the United States or to any other tertiary facility anywhere in the world. In that regard, that's where CRNAs in the military, as Miranda has stated, my colleague has stated, we have provided anesthesia care since the Civil War. The AANA has been around since the 1910s, and we have been an ardent supporter of safe anesthesia care in this country. There are approximately 58,000 CRNAs in this country. We provide approximately 60% of the anesthetics provided or served on a daily basis in this country, done safely and with care and compassion. Back to my military experience. When I was, for 2 years, I spent 4 years in Washington State at Madigan Army Medical Center. I was a member of an educational committee where I taught anesthesia providers, taught CRNAs. We graduated anywhere from 5 to 7. Most of those anesthesia providers went on to provide exemplary service in battlefields in Afghanistan and Iraq, some returning wounded. We provided that anesthesia care from day one to allow them to know that they are going to be providing anesthesia care on a forward environment, taking care of soldiers by themselves. In addition to that, one of my other tasks, I was selected to sit on a committee that reviewed any sentinel events. Sentinel events in any medical facility are loss of life or limb, inadvertent loss of life or limb. While on this committee, one of the things that I learned was accidents happen. We are all human. Humans make mistakes. Irrespective of the initials after your name, anybody can make a mistake. What we try to do is prevent those. Our educational process is geared towards keeping patients safe and preventing these things from happening and learning from these lessons. These are some of the things that I have taken away from that. Since I have been out of the Army, we have lived in Nevada since 2008. For 9 years, I was a member of a 4-person CRNA group in Elko, Nevada. We provided anesthesia care 24/7, 365 for the entire facility. We covered the operating room, obstetrics, the emergency room, everywhere that anesthesia is required. We did it safely, we never missed a call, and we provided the care that is required of our patients. And we did it every day without skipping a beat. I have had multiple experiences that I would like to share with you towards the end of this presentation, but primarily what that will do is emphasize the requirement that we have, that we need to get this bill passed. 198 needs to be passed primarily because anesthesia providers are trained in pharmacology, pathophysiology, physiology, and anesthesia, and we are trained very well to provide those services. What we would like to do is just let you know some of the things that have happened to me over the years, but also that providing this bill and providing the passage of this bill would facilitate that care. A lot of the care that's done, I currently practice both in Las Vegas and in Pahrump, Nevada. The majority of our patients are Medicare, Medicaid, who would not have access to anesthesia care otherwise if we were not available to provide that service. We do provide a lot for the rural patients in the state, and we provide a lot for the cities as well. What I would like to talk about, I've had a couple of experiences over the years, and one of the things that, or the components of this bill is the prescriptive authority. I've had calls on OB. The adage that nothing good happens after midnight applies especially to obstetric anesthesia. When you get called in at 2 in the morning and you are told that a patient is hypotensive, meaning their blood pressure is low, and you need to come in and help, you ask, well, hasn't this patient delivered already? Yes, this patient has already delivered. And when you ask, have you called the physician who is in charge of the patient, their obstetrician? Yes, we have, and they have not answered the phone. Could you please come in? 2 in the morning, you get up, you get your car keys, you drive into the hospital, and you find a patient who is dying, who is in extremis, who is hypotensive, has a low blood pressure. And you look at her and you realize that you need to do something immediately. Your experience tells you that you need to draw blood, you need to get transfusions started, you need to get IVs going, and you need to do things to keep this patient alive immediately. Included in this is pharmacologic management. Pharmacologic management of medications that we need to administer, that we have the experience and the knowledge to administer, that we would like codified into law. And if we do not have that ability, that opportunity, and I have no physician available that I can ask to sign an order for, this patient would die. This is not an unusual occurrence. Another event that occurred to me, 3 a.m, again, obstetrics. You get called in. There are multiple different types of cesarean sections. There's an elective, there's an emergency, there's a stat, and there is a crash. When you get a call at 3 a.m. for a crash C-section, and you have a normal 20-minute drive and you make it into the hospital in 12 minutes, wondering if you're going to get pulled over by the sheriff's deputies in Elko County, but you do not, and you get into the hospital and you come into the delivery room and you have a mother who is up on all fours screaming with a nurse holding the baby inside her, and the surgeon ready to go for surgery, ready to deliver this baby, and you immediately take a cursory health exam, you get the patient flipped over, you put oxygen on, you put her to sleep, you intubate her, and within 30 seconds the baby is delivered. That baby is delivered, mother does well, baby does well. Realizing that in the course of this anesthetic, by yourself, you have administered at least 10 to 15 different medications that you do not have the time to ask a physician or ask another provider to write an order for. These are the types of circumstances that we are trained for. These are the types of medications that we use on a daily basis that we would like codified into law, that we are able to use these on a daily basis. And this is why we have requested and we fully support 198. So in conclusion, I've discussed what CRNAs bring to this state and the citizens every day in every location. I implore you to provide these dedicated providers the tools they need to continue to provide safe and timely anesthesia care every day in this state. And on that, I close. Thank you very much. I appreciate your time.
Are you ready for questions, Assemblyman?
Yes, thank you, Chair, Vice
Okay.
Chair.
Are there any questions from the committee? Senator Stone.
Thank you for the presentation. Can you just talk about the present contemporary practice today, the relationship between the nurse anesthetist and the physician, and the steps that have to be undertaken to put somebody on anesthesia? I assume that a CRNA can recommend certain anesthesia. Is it collaborated with a physician today to administer and to provide these services?
Thank you for the question, sir. Arthur Savanak again for the record. 3 different practice models currently in this state. There is medically directed, basically where a physician will tell a CRNA or an anesthesia provider how to conduct an anesthetic. There is an anesthesia care team where there is a cohort of CRNAs and anesthesiologists. Typically, the way it works is usually if the anesthesiology department trusts the CRNAs, they pretty much allow them to practice the way they need to practice. And the third practice model is basically where CRNAs practice by themselves, and that is primarily what we see in the rural parts of the state. But the conduct of an anesthetic involves initially preoperative evaluation, where you take a health history, you review labs, you review any past events that the patient may have had with an anesthetic. From that, you formulate a plan to provide an anesthesia or to provide an anesthetic for that patient. So you bring the patient back into the operating room. You take into account their history. You take into account their medications. You take into account any past events that they have had. There's a couple of critical events that can occur in anesthesia that are exceedingly rare, that you have to listen. You have to listen very well to what the patient says. The patient is always right because they know what has happened to them in the past, so you listen. So there's the conduct of the anesthetic, and then post-operatively, you get the patient back. If you have intubated, you put in a breathing tube to conduct a general anesthetic. At the end of the surgery, you get that breathing tube out, you bring the patient over to the recovery room. In most facilities, you have highly trained recovery room nurses who will pick up on things and will pick up if there's a problem, they will let you know. And in a bigger facility, you might have 1 or 2 physicians or 1 or 2 CRNAs that are basically floaters, that if there is an occurrence that happens that requires immediate intervention, they're available to help. In a smaller facility, typically, the nurses are probably a little bit more trained because they're just on their own. So if they know that they have a problem, they need to let you know immediately. So airway issues, breathing issues, fluid issues, bleeding issues, things that need to be brought to our attention are brought to our attention immediately.
And if I can follow up, who's officially writing the order for the anesthesia or pharmaceuticals?
Typically the order is, it's not really an order that's written. It's more of a formulation of a plan. The orders that we write typically are preoperative medications. So we frequently we'll give medications that are antiemetics to prevent patients from throwing up, and nonsteroidals for pain. If the patient has any breathing issues, they may need a breathing treatment, some type of breathing treatment. If they're hypotensive when they come in, if they need fluid or they need some fluid bolus, or if they're bleeding in a trauma situation, obviously things are going to be a little different. But typically we would write the orders. So whoever the anesthesia provider is for that patient that day would write those orders.
Is that based on a collaborative relationship with a physician, that these orders have been approved by a physician to be administered under certain cases?
I would say more on an individual basis. Now, facilities do have order sets. Some facilities do have order sets that patients come in, and if say a patient is a diabetic and they can't get a steroid, that you can X off whatever medication you do not want to administer to that patient. So you're going to have a standard order set that you can draw from. But typically, it is whoever the anesthesia provider is, whether it's the CRNA or the anesthesiologist, is the one that will go ahead and write those orders.
I think you've demonstrated through the testimony that the CRNAs are very well-trained individuals. But what is their limitations, if you will, in compared to a fully fledged physician anesthesiologist? Where would a physician anesthesiologist need to be involved in a case where a CRNA maybe is facing circumstances that they're not prepared or trained to accommodate? I mean, every anesthesia patient is different, and there's always
Absolutely.
a possibility that something can happen, and there's a certain percentage of people that don't make it out of anesthesia, whether a physician's providing under CRNA. So what are the limitations of CRNAs?
The limitations are more facility-based. So many, I've had many of my colleagues, that whether I was in the Army or civilians, that have gone on and they provide anesthesia in a cardiothoracic setting. Some of the most critically ill patients and some of the most demanding technological anesthetics that you're going to provide, neurosurgery, cardiothoracic, a small percentage of cases done annually, but still they are done. Not every CRNA wants to do those, and it's not a requirement that you're going to graduate on day one and go in and take care of somebody who's having a cardiac bypass. So again, a lot of that is more experience-based. Many CRNAs do not want to do those cases because of the demands and because of the liability that's involved. Many anesthesiologists don't want to do those cases as well. So it's pretty much in every human endeavor, there are the good and there are the that are passable. Doesn't matter your education. I've seen both sides. I have seen both sides, and so it is. It all depends on whatever the group states. If the group states that if you want to do hearts, you can do hearts. You do hearts. If you can do heads, you do heads. And if they see you do a few and they realize you know what the heck you're doing, then you're going to go ahead and you're going to continue to do that. And they're going to find somebody that they know that knows what they're doing, and they're going to keep them there. So.
And then finally, with this aspect of the bill, are there restrictions with federal plans, Medicaid and Medicare, that would mandate an anesthesiologist oversight or putting requirements on what CRNAs can do?
That I am not sure on that, sir, and I'd have to get back to you. I do. I kind of derailed my train of thought, but the big thing is one of the big things about this, and I know. This bill has been up for a while, but part of the bone of contention was that CRNAs are prescribing. We're not looking to prescribe medications outside of a facility. What we're looking to do is to use our expertise and our knowledge to be able to provide patients in an inpatient or an outpatient setting within the facility, whatever facility it is that we're working at, with the medications that they need for that specific procedure. And we need to be able to do that. When I'm by myself in Pahrump, if I have a patient that comes in that has significant medical problems that I need to look at, and with my experience, I can say, I can give this or I can't give this. And if I have a question, I have somebody I can call. But that's pretty rare. I mean, I have to go back and look at what their primary care physician has stated, and I need to go ahead and make a judgment on my own.
Thank you. Assembly Orlicker, if we just turn really quick to telehealth, can you talk about who's going to be providing that telehealth? Is it going to be Nevada?
Senator Stone,
Yep.
our legal has advised that that is not germane to the bill and it won't be added.
Oh, it's not? Okay.
Correct.
Then I just will withdraw my questions. Thank you.
Okay, thank you. Senator Buck.
Thank you, Chair Lang, and thank you so much for your service. My son has, the past 10 years, has been at Fort Bragg in Special Forces, Green Beret Ranger, and so thank goodness he has not needed your services. I was just wondering, because I'm a little naive to the whole medical field, but what is the education difference between a physician of anesthesiology and then the CRNAs?
Thank you, ma'am, and thank you for your son's service. Hoo-ah to him, okay? But my son was born at Fort Bragg, and if I never go back there, I won't complain. But anyway, CRNAs are typically, we are registered nurses to begin with. So we have 4 years of nursing school, and the vast majority of anesthesia programs, CRNA programs in this country, require a minimum of 2 to 4 years of critical care experience. Critical care, cardiothoracic, coronary care, medical ICU, surgical ICU, where you're managing one patient who is critically ill with multiple lines, multiple different medications. So you come in with a base of pharmacology and a base of monitoring and a base of caring for a critically ill patient before you even start school. So, excuse me, that is the basis of CRNA education. So you go on to educate. As I stated, I was an educator for 4 years when I was in the Army, teaching nurse anesthetists. The Army program, different from most other programs, but we would have 17 months where it would just be didactic book work, and then they go on to do clinical. And in the clinical, from Monday through Friday, 5:30 in the morning, 5 in the morning, until 6 or 7, whenever the day is done, you are doing cases in the operating room. So all we do is learn how to do anesthesia in the operating room. Airway management, fluid management, line placement, the things that are germane to an operating room in the United States. Anesthesiologist, 4 years of undergraduate, typically in a hard science, 4 years of medical school, and then they do 1 year of internship, and then 3 years of, typically 3 years of an anesthesia residency. So the majority of their anesthesia education is in that 3-year residency. They do have probably more in their 4 years of medical school, a little bit more in the way of background, but as far as their anesthesia education goes, it is 3 years.
And is your experience in the military, is that different than just a normal civilian?
The one thing the military emphasizes is that from day one, from the day you graduate, you may well be on a battlefield caring for a critically ill soldier. Not every civilian program makes that emphasis because it's probably not going to be a necessity. The military CRNAs are a minority of CRNAs that practice in this country. But CRNAs do get an education that involves all of those things. So the minimum standard is met. The amount of cases that are required for them to perform in order to graduate, the amount of lines that they need to place, the amount of different subsets of cases, thoracic, neurosurgery, cardiac, obstetric, epidurals, spinals, all the things that we do on a daily basis. These are the types of things that they have to have a minimum number of in order to graduate. Some facilities, going back to Senator Stone's question, some facilities, they may not allow CRNAs to perform spinals or epidurals or lines, and they'll go into that job understanding that this is going to be a limitation of their practice. Some facilities, when we were in Elko, it was us. And we would have trauma. We would have calls at 2 in the morning, 3 in the morning, and there was no backup. And if you were on a weekend and your partners were gone, it was you. So you were in the emergency room, you were in the operating room, you were in obstetrics, and you had to be everywhere at once, and you pretty much had to cover the entire facility. Going back to that, in Elko, and I didn't even cover it, but in Elko, when we presented to the Assembly, we did have a letter from the CRNAs that were practicing in Elko that basically they became de facto intensive care physicians during the COVID crisis because the intensive care physicians and the hospitalists were overwrought. There was so much going on, they couldn't take care of everybody. The CRNAs, on their own, took it on themselves to go into the facility, take call overnight so the hospitalists could go home and get some rest. When the patients would come in, critically ill COVID patients would come in, they intubated them. They taught the nurses how to provide care for the COVID patients by flipping the different treatment modalities that we learned during COVID, during the pandemic, that kept these patients alive. And it was the CRNAs that kept the facility going for approximately 2 to 3 months during the summer of 2021. So.
Thank you. Senator Scheibel.
Thank you so much. And first, I think I need to apologize because I think we had a meeting scheduled yesterday to go over my questions, and I was stuck in committee. So I apologize. I didn't get to ask offline first, but I'm just hoping that you can help me understand a misconception I think I have about this bill, frankly, which is that, I mean, I've also been in the hospital, and, you know, I've been cared for by doctors and I've been cared for by nurses, and I don't think it's any secret that nurses run the show. And, you know, I'm always happier to see a nurse walk in my room than a doctor. Sorry, guys. But, you know, they have more patient contact. They are, you know, on the ground. They're such an important part of the care team. I also know that the doctor, the registered physician, has the ultimate responsibility for the patient care. And that comes with, and I don't just mean legally, I mean, you know, in that medical practice, the doctor holds the ultimate responsibility for the case and for the management and for the care of that patient. And so it seems to me like this bill, and I completely understand that when, first of all, that CRNAs are qualified to administer anesthesia and that there aren't always doctors available. And even if there were, you wouldn't necessarily get better care from a doctor than a CRNA. I understand all of that. What I'm struggling with is this seems, if the idea is to increase access and to increase the number of providers that are available, especially in rural areas, it seems like a little bit of an overcorrection. That if the problem is that, well, first of all, it seems like the problem is not that CRNAs are not in the operating room or in the hospitals because there's a lack of doctors. It sounds like they're going in anyway. So I'm not sure how this bill gets us more providers than we already have. And second of all, I don't totally understand why the answer to the problem is just remove the supervision entirely, allow them to operate independently instead of modifying that relationship so that supervision can be done in a less prescriptive manner. More CRNAs can be supervised by a single anesthesiologist. Something else. Help me understand how this solves the problem and why this is the answer.
Thank you for your question, Senator Scheibel. Miranda Hoover for the record. So I'll take it in kind of small chunks. So first is, this bill does not remove or add any additional physician supervision. Secondarily to that, the administer, order, possess, prescribe pieces are part of the CRNA scope of practice that they already have. To give just a little bit of history, a few years ago, we were informed, and which was part of my bill testimony, about who actually has jurisdiction over CRNAs. They are nurses, yes, first by trade, but they also have the ability to prescribe dangerous poisons and controlled substances. And so in the past, CRNAs work, frankly, either under the DEA number of a hospital and or a healthcare facility, or they work under the DEA number of a physician. And so because there has been this unknown from a few of the regulatory boards, there's been this unknown about how CRNAs can actually prescribe and how that is part of their scope of practice, even though it's currently in the NAC, but it's not in statute. And so we've been running into numerous issues across the state and numerous healthcare facilities and hospitals telling CRNAs that they can no longer practice within their scope, and that it will be required that a physician who has a DEA number must first write the order, and then the CRNA can do their job. And so this bill simply alleviates that issue and simply puts into law their full scope of practice, which pretty much is exactly taken from the NAC, just to put into law, and really clarifies both for the Board of Nursing and Board of Pharmacy who has jurisdiction over what, and ensures that CRNAs are part of that definition of practitioner, and that they do have to go pay that $300 fee. They do have to go in and now be part of that whole DEA process. I hope that answers your question.
It does. Thank you.
Thank you. And seeing no further questions, if you want to step back, we'll take public comment. Anyone wishing to give public comment in support of Assembly Bill 198, please come to the table. Sir, you can begin when you're ready.
Good morning. My name is Landon Mortson, and I'm a CRNA and the Director of Anesthesia at Humboldt General Hospital in Winnemucca, Nevada. Some of you may be familiar with Winnemucca, but it's a very rural and underserved community. I enjoy living there with my wife and 4 children. CRNAs have been the sole providers of anesthesia there for almost 30 years. Without CRNAs, Winnemucca doesn't have the ability to do emergency or preventative surgeries or provide obstetrical services. People have to travel hours to receive it elsewhere. We do much more than that, though. We are the ones that the doctors in the community turn to in codes, difficult airways, challenging vascular access, and other emergencies. They rely on us because we are highly trained individuals who are experts at what we do. I've put breathing tubes in babies when others couldn't. I provided pain relief for distressed mothers and helped improve and even save many of my fellow community members' lives. We spent years becoming nurses, years working as nurses, and years in anesthesia school. I trained for 10 years to become a CRNA. What we are asking for in this bill is not unreasonable or dangerous. It is what we were trained to do. I know of no other state that has restricted CRNA practice as much as Nevada. Research shows that anesthesia care provided by CRNAs is equally as safe as that provided by physician anesthesiologists. CRNAs are the ones in the room by the patient's side making critical decisions for the vast majority of surgeries in the United States. I'm baffled that with the high level of training and safe care we provide, that we're not allowed to practice for what we've trained to do. Nevada has dire need of anesthesia services, and CRNAs are here. We're qualified and we want to serve. My kids, my wife, and my community members deserve access to anesthesia care. Please help us provide it in a manner that makes sense. Thank you.
Thank you. Next person, please.
Good morning, Madam Chair and members of the committee. Sarah Adler, Silver State Government Relations, today and at this moment representing the Nevada Advanced Practice Nurses Association, Nevada's Association of Nurse Practitioners. So we are in NAPNA is in full support of this bill because in 40-plus states, CRNAs are recognized as advanced practice nurses. And something that we are all in Nevada acutely aware of is our shortage in healthcare providers. And as providers are newly trained after they accomplish this extensive training that you have just been exposed to, they're going to choose to practice in a state where they can use the full scope of their abilities. And we are at risk of losing newly trained CRNAs to other states who recognize their full scope. Now, it is understandable, this situation that is seeking to be clarified by this statute is understandable. We are this year in an environment that is looking at medical liability. And so it's understandable that licensing boards want absolute clarity on the authority of practitioners to do what they are proposing to do. So this bill is appropriate and it's necessary. I myself have worked in rural Nevada most of my career, and I know these hospitals, and to think that people could be without access to care because they lack access to a highly trained anesthesia professional is something that we don't want and we don't need to have if we move forward with AB 198. So thank you very much.
Thank you. Next person.
Good morning. My name is Allison Lofton. I am a full-time nurse anesthetist at Carson Tahoe Hospital. I've been a CRNA for 8 years, and I came here this morning from a 24-hour labor and delivery call shift. This means that for 24 hours, I was available to be called in throughout the day and night to perform epidurals and provide the anesthesia necessary for emergent C-sections. Prior to becoming a CRNA, I was an ICU nurse for 7 years. I bring 8 years of autonomous nurse anesthesia practice from my prior practices in Washington State and Guam Territory. I have particularly enjoyed providing epidurals and spinals for pregnant women, helping them through this incredible yet painful hours of their labor. I am an expert providing anesthesia care for the following surgeries: pediatrics, neuro and spine, thoracic and lung, vascular, orthopedics, trauma, laparoscopic surgeries, and as well as epidurals and spinals for labor and delivery. I am taking more call shifts because we are distressingly short on CRNAs, providers who are willing to practice labor and delivery care here. This is because we're trained and educated to perform specialized services and not able to fulfill this scope of practice in Nevada currently. AB 198 is a step in the right direction to rectify this shortage of anesthesia providers here. Thank you.
Thank you. Please go ahead.
Thank you, Vice Chair Lang, and thank you, committee members. My name is Jennifer Brown. I am the Chief CRNA at Carson Tahoe Hospital. I have been a nurse for 20 years and a CRNA for 14 years. I hold licenses in Alaska, Maine, Hawaii, and a DEA license also in Alaska. I am reminded again and again that CRNAs are one of the best kept secrets in healthcare. So many people have no idea that we even exist, yet nurses have been delivering anesthesia independently since before anesthesiologists were a specialty of physicians. In fact, as Art said, nurses have been delivering anesthesia in the U.S. military since the Civil War. That's over 150 years. Today, there are 44,000 CRNAs and 31,000 anesthesiologists practicing in the United States. That's 13,000 more CRNAs practicing than anesthesiologists in the United States. At Carson Tahoe, our staff consists of 10 CRNAs and 3 anesthesiologists. Studies have shown and played out that CRNAs and physicians provide the same quality of anesthesia care. That is why in every state, anesthesia teams consist of a mix of CRNAs and physicians. And in Nevada, we know specifically that our rural hospitals are CRNAs only. We just can't provide anesthesiologists in our rural communities. They are just not going there. Sometimes our bills that come up are intended to fix the language of previous bills that weren't perfectly written. This is one of those times. The purpose of this bill is to codify language and align Nevada laws. Everyone knows that we need more healthcare workers. This bill will fix confusing language that keeps providers away. And if this bill does not pass, myself, Allison, and many more providers will have to leave the state. Please pass AB 198. Thank you.
Thank you. Next person, please.
Good morning, Madam Chair and committee persons. I'm Dr. Jeffrey Meter. I am the Chief of Surgery at Humboldt General Hospital in Winnemucca. And I'm just going to mention a different aspect of this bill, the AB 188, which I think is so important. The CRNAs that I work with at Humboldt General are excellent, and I'm always comfortable with their care. But the way the law is written right now, I need to supervise the care that's given and the medications that are given, and I do not have the training or experience that my CRNA partners have in giving those medications. And I think it's a bit insane that I should be supervising those things. We can't have anesthesiologists. We'd need to hire 2 or 3 anesthesiologists at Humboldt General in order to cover 24/7 to supervise the CRNAs, and that's just not possible. So I can foresee that if we don't change this, that we'd not be able to provide surgery in Winnemucca, and if we can't provide surgery in Winnemucca, there isn't going to be the revenue needed to keep the hospital open, so yet one more critical access hospital would disappear. And I think, to me, that's the main thing. Recruiting surgeons that have to supervise anesthesia care is going to be very difficult, and so I think those are some different issues in terms of care that I think are really important.
Doctor, could you please spell your last name for our secretary?
Yes, Meter, M-E-T-E-R.
Thank you so much, and thanks for your testimony. Next person.
Thank you. Blaine Osborne, Nevada Rural Hospital Partners. Happy to be here in support of AB 198. Thanks.
Thank you. Anyone in Las Vegas? BPS, is there anyone on the phone lines in support of AB 198?
If you would like to testify in support of AB 198, please press star 9 now to take your place in the queue or raise your hand in the Zoom window.
Madam Vice Chair, members of the committee, this is Matt Robinson for the record. I'm the Director of Public Affairs at Argentum Partners, and I'm here today on behalf of Carson Tahoe Health. You've already heard from several of our providers. Obviously, we're here in support of AB 198 as we all look to address the very serious provider shortage and access to care issues in our state. Allowing these providers to practice to the fullest extent of their training is a great and easy to access tool. This bill, like other bills you're considering this session, like the PA bill, do just that. We urge your support of this very important measure as we all work together to increase patient outcomes. Thank you.
Thank you. Next caller, please.
Good morning. My name is Morgan McCarroll. I'm a physician and I'm the chief of anesthesia at Carson Tahoe Hospital. I've had this role since January of this year. My experience has been primarily working in Reno at renowned St. Mary's and Northern Nevada Medical Center. I spent 19 years in that community, and I've received numerous patients from rural Nevada, from the outlying hospitals, and that's what I'd like to follow up on is on Senator Stone's question, I believe. Our rural hospitals provide excellent care to our rural Nevadans, and when those patients are either very, very sick or very, very complicated for whatever reasons, those patients get transported to either a hospital like Carson Tahoe or like Renown. So these hospitals are more likely to have care team models or anesthesiologist models of care. The point here is that it's not necessarily a CRNA limitation that prevents CRNAs from practicing in rural environments. It's the hospital system in general that's not able to take care of very complicated patients. So those patients are going to go to the larger facilities, the tertiary care centers, where they'll be managed by teams of either physicians or physicians and nurse anesthetists. So basically, as the complexity of the patient gets higher, the patient is more likely to go to a more well-equipped facility for managing such patients. I believe that nurse anesthetists do a fantastic job. My experience with them started in my residency more than 25 years ago, and I also had experience working side by side with CRNAs in New Jersey during the COVID epidemic. Nurse anesthetists in New Jersey were managing the COVID units in the same way that physicians were, very, very much like Mr. Savignac mentioned with COVID care in Elko. Nurse anesthetists have played a very, very critical role in managing COVID patients in intensive care settings. Senator Buck's question about differences in training.
Doctor?
Yes.
We allow 2 minutes for comment, and you're over, but I'll let you go ahead and finish up if you could, please.
I'll be very, very quickly. My training, I finished the 26th grade including fellowship, and that's the training is slightly different, but I believe it's complementary to nurse anesthetist training. And I believe very strongly that Assembly Bill 198 is in the best interests of nurse anesthetist practice. And I have actually had nurse anesthetists tell me that the restrictions of practice in Nevada has prevented them from actually working in Nevada. So removing some of these restrictions will actually improve access to care in Nevada. So I appreciate your time. Thank you very much.
Thanks so much. Next caller, please.
The public line is open and working. There are no callers at this time.
Okay, anyone in Carson City wishing to speak in opposition to Assembly Bill 198?
Hello, thank you, Madam Chair Lang and the members of the committee. My name is Dr. Shana Richardson, SHAINA-RICHARDSON, and I am a practicing physician anesthesiologist, primarily in Northern Nevada. I also am just coming off of a 24-hour shift, so I apologize if I have to gather my words a few times. It's my third one of those this week, actually. A few points. I had a whole lot of things I wanted to say, but instead I would like to just address a few points that were made during this testimony thus far. First, as a sixth-generation Nevadan, it is Nevada. And number two, there is no independent practice of CRNAs in Nevada. This is per federal guidelines. I actually have the exact federal CMS Code of Regulations, Title 42, specifically states that certified registered nurse anesthetists need to practice under the supervision of a physician unless opted out under Section D of that regulation. Nevada is not one of those few states that opts out of that requirement, and the vast majority of the anesthetics provided in the United States are done under the team care model, supervised by a physician. Another point that was asked earlier was about the level of education, and I think that no one would doubt the amazing work experience that many of us anesthesia providers of all types get while we are working. However, I also don't think anybody could quickly ignore the level of education and the difference, which is 2 to 3 times that between a physician and a nurse anesthetist. The education that we receive, even if it is in science and bench research and critical care and pharmacology, those things, they matter. It's the foundation on which our experience evolves and is built. So if we get a really strong education, and I went to school for a very long time, about 13 years, I feel like those experiences were vital to my training later on, and then further on in my experience, because everything that happens, every patient I take care of, the idiosyncrasies, the intricacies of that care builds on that foundation of my education. And so not wanting to discount the amazing services provided by an anesthesiologist assistants and certified registered nurse anesthetist in the anesthesia care team model, I think that care under the direction of a physician is the safest way to provide anesthesia. And this has been shown in multiple studies that are not industry funded, the largest one of which was the Silber study that looked at over 250,000 anesthetics and found that when a physician was specifically involved in the care and the delivery of that anesthesia, there was better actual outcomes in that 2.5 per 1,000 complicated cases, fewer deaths. That's not an insignificant number when we provide a service that is extremely safe, because we have gotten so good over the years at providing safe anesthesia care. So if we can save 2.5 patients per 1,000 complicated cases by having a physician involved, I think that's something that we deserve. And I do not believe that those in rural Nevada deserve any less care than those in the cities. So I appreciate the passionate testimony given by everybody here. I know we all have lots of stories to tell about intubating babies and crashing C-sections, but I oppose this amendment because I believe that Nevadans deserve to have the safest care possible, and that's delivered by a physician. Thank you.
Thank you. Next speaker, please.
Thank you, Madam Chair. For the record, Susan Fisher with McDonald Carano, speaking now on behalf of the Nevada State Board of Osteopathic Medicine, the Nevada State Society of Anesthesiologists, and also the Nevada Nevada Orthopedic Society. They are all opposed to Assembly Bill 198. You have in the exhibits for this bill online the federal code that was referenced by Dr. Richardson, if you'd like to read the entire thing. We also have submitted, there's a letter of opposition from the American Medical Association, and they've asked me to read portions of it into the record, which I will do. I won't read the whole thing because you can read the rest of it, but the strong points here. The AMA strongly supports a physician-led care team, with all members of the team working together to ensure patients receive the full spectrum of high-quality care. Yet AB 198 effectively removes physicians from managing key aspects of patient care. The AMA also believes when AB 198 is not the right approach to expanding access to care and may have devastating effects on patient safety. This was illustrated by a recent study published in the Journal of Internal Medicine, which compared the prescribing patterns of physicians to other non-physicians, specifically nurse practitioners and physician assistants. The study found that non-physicians are more likely to prescribe opioids compared to physicians. 6.3% of nurse practitioners and 8.4% of physician assistants prescribed opioids to more than 50% of their patients, compared to just 1.3% of physicians. Nurse practitioners are 20 times more likely to overprescribe opioids than those in prescription-restricted states. The letter goes on. We know that CRNAs are highly trained physician extenders, as are physician assistants. And in this session, we've seen quite a bit of scope creep, where we're wanting to remove the physician from the physician assistant model, and now removing the physician from the CRNA anesthesia delivery model. So we are adamantly opposed to this bill. Thank you.
Thank you. Please go ahead.
Good morning, Chairman Lang and members of the committee. My name is Mary Nakashima Nielsen, and I'm here on behalf of the Perkins Company and the Nevada State Medical Association. Today, we want to echo the importance of CRNAs across the state in a comprehensive care team. On behalf of NSMA, we want to call attention to a few concerns in the measure. The NAC, or Nevada Administrative Code, the presenters are referring to, still requires supervision. If the goal is to codify the code, we would ask the committee to look at the code. It's NAC 449388. Again, supervision is a requirement under the NAC, and we believe this measure goes beyond codifying the existing code. The patient being under the care of a physician and a supervision requirement of a CRNA are two different things, and that's the way the bill is written. The NAIC specifically states in subsection 2, the organization of anesthesia service must be appropriate to the scope of the services offered by the hospital. Anesthesia may only be administered by A, a qualified anesthesiologist, B, a doctor of medicine or osteopathy other than an anesthesiologist, C, a dentist, oral surgeon, or podiatrist who is legally authorized under state law to administer anesthesia, or D, a certified nurse anesthetist who is under the direction of the operating practitioner of an anesthesiologist who is immediately available if needed. As to the 44 states mentioned earlier, CRNAs may have prescriptive authority, but they don't have independent practice, which is where we have concerns with this measure.
Thank you. Is there anyone on the phones BPS wishing to speak in opposition?
If you would like to testify in opposition to AB 198, please press star 9 now to take your place in the queue, or raise your hand in the Zoom window.
Good morning, Vice Chair Lang and members of the committee. For the record, Jerry Matsumura, M-A-T-S-U-M-U-R-A. I'm calling in to testify in opposition to AB 198. I'm ditto what the other opposition testimony had said. I just wanted to add a couple things on Dr. Richardson's description of education. Ms. Hoover stated that the CRNAs do get 9,369 hours of training, and Mr. Samignac confirmed that a lot of that is 2 to 4 years of critical care nursing. That is not the same as, while very important experience and highly educational, it's not anesthesia experience. Anesthesiologists, as mentioned, get a bachelor's degree in hard science, 4 years of medical school, the last 2 years of which are clinical, which amounts to about 6,000 hours, and 4 years of anesthesia residency in my case, which amounted to about 20,000 hours. So that's quite a difference in education. And to keep it short here, I just want to also mention that Senator Scheibel seemed to hit a good point. It doesn't, AB 198 won't be adding providers to the area. It just expands the scope of practice of one category of provider. If a nurse anesthetist wanted to practice in Nevada, they've probably already moved here to Nevada. So I have given testimony before to the legislature that we do have a shortage of anesthesia providers in state. However, I do not feel it should happen by changing state regulations and statutes to provide a lower standard of care. Thank you.
Thank you so much. Next caller, please.
Good afternoon, Chair and members of the committee. This is Elliot Mallon for the record on behalf of the Nevada Osteopathic Medical Association. I will keep this very short. We are in opposition, and I would like to ditto everything that my colleagues just said. Thank you very much.
Thank you. Next caller, please.
The public line is open and working. There are no callers at this time.
Thank you. Is there anyone in Carson City wishing to speak in neutral?
Thank you, Madam Vice Chair. Michael Hillerby for the record, representing the Nevada State Board of Nursing and State Board of Pharmacy. At the risk of potentially further muddying the waters, we'll do my best to answer questions or pass along questions and get additional information based on what we've heard today, or if you have them. The decision on the scope of practice of any provider is, of course, the legislatures. The boards my two clients do not take a position on that. So whatever you decide is appropriate for the CRNAs is, of course, up to you and something we will work to implement. As you've heard, there is some confusion because of the existing status of a variety of things. The CMS directive you heard about, which applies to reimbursement for Medicare and Medicaid, not to the overall scope of practice. There is the administrative code that you heard about in NAC 449. We have a similar language that has added to the confusion in NAC 632-500, where you will see the words under the direction, under the order. You don't see supervision. Whatever you end up deciding to do today, or the legislature in this process, some clarification will be very helpful for the boards. Some of these regulations with some potentially conflicting language date back 20 or 30 or at this point almost 40 years. So perhaps with the guidance of Mr. Fernley and Mr. Malgarejo, they might be able to help provide some guidance to the committee to do that. Currently, CRNAs are not able to independently prescribe. Some of the confusion that has arisen is because of those old regulations that use the word select, order, and administer, and it's the order word that causes some of the confusion. In NAC 632-500 is clear that a certified CRNA may, in addition to those functions authorized for the registered nurse, perform the following acts when it has been determined by a patient's physician, dentist, or podiatric physician. So again, some clarification in the state law would be very helpful, both for the Board of Pharmacy. If you want CRNAs to be included in the list of practitioners who can prescribe possess and administer, to make that very clear, particularly on the prescription part, in whatever limitations you may want to put on that. In NRS 453 and 454, as you see in the bill, that would clarify things and be very helpful. And if you want to use, clarify either direction, supervision, as you look at this, and you also have SB 363, I believe, which is heard today in Assembly, Commerce, and Labor. That also deals with CRNAs and limits that scope to within critical access hospitals. So there are a couple of pieces moving through. I'll stop there. Again, some clarification would certainly be helpful for the two boards so that we can enact a clear policy as determined by the legislature. I will stop there and be happy to answer questions if I can or get you additional information.
Does anyone have any questions of Mr. Hillerby? Senator Buck.
Thank you. I guess I want to ask to the bill sponsor. So I just want to clarify because there's been a lot of testimony and I'm kind of unclear. So for the record, this bill is not asking for independent practice, correct?
Thank you. Senator Michael Hillerby, again, I don't believe that's the board's interpretation. You still have to be working with a patient who is under the care of a physician, podiatric physician, or dentist. So the question is sort of what level of discretion. Again, you have, I think potentially today there's an amendment that may be presented on the bill in the Assembly side that will say under supervision. So it is not independent practice in that they are initiating the care of a patient starting from scratch, the way an advanced practice registered nurse may, or a physician, or some other providers. It still has to be done within the appropriate setting and with a patient who is currently under the care of one of those two types of physicians or a dentist. But I would certainly rely on your committee staff and council to provide any clarification if that's appropriate.
Mr. Fernley.
Thank you. So, as Mr. Hillerby mentioned, the bill does require the patient to be under the care of a licensed physician, podiatric physician, or dentist. And that, I think that basically gets interpreted by the boards as to what it means to be under the care of one of those professionals. And that is how the language, that is modeled off of the existing language governing CRNAs, and there have been various regulations adopted to set forth, what exactly that means in particular settings. So Mr. Hillerby's correct that the bill would require there to be a patient under the care of a physician or a dentist. What exactly that means might be left to the licensing boards to figure out how to further define that.
Thank you. Any further questions? Senator Scheibel.
I wanted to clarify when we talk about the boards that would have to be interpreting this, which boards would be interpreting this?
So thank you, Senator Michael Hillerby. So the scope of practice issues would be for the State Board of Nursing. The issues regarding access to drugs and how those can be possessed and administered would be with the State Board of Pharmacy. And I can tell you both boards will work together and work quickly to update any of their regulations. We would have to talk to the Department of Health and Human Services, for example, and perhaps some guidance from Legislative Council on the reference you heard to the Nevada Administrative Code 449, which is facilities. So for those two pieces would be the State Board of Nursing and the State Board of Pharmacy.
Thank you so much. And anyone on the phones wishing to speak in neutral?
If you would like to testify in neutral for AB 198, please press star 9 now to take your place in the queue or raise your hand in the Zoom window.
Hello?
Please go ahead.
This is Yvette Williams. I'm calling on behalf of the Clark County Black Caucus. Just wanted to change our letter of support. We sent a letter of support in for the conceptual amendment, and since that's not being heard today, we'd like to change our support to neutral, and so I just wanted to make sure that was on the record.
Thank you so much. BPS, is there anyone else on the phones in neutral?
There are no callers choosing to testify.
Okay, thank you. With that, we'll ask the Assemblyman to please come back up and give us some closing comments.
Thank you, Vice Chair and members. So
I'm sorry, before you start, could Senator Buck ask you a question? We have a question from Senator Buck.
Oh, sure.
Thank you so much, Chair Lang. I was just wondering, it sounds like under the care of a physician seems different than supervision of a CRNA. So could you describe both?
So I'll start, and I think my co-presenters will have more to offer. David Orient-Licker for the record. So under, as Council Fernley indicated, under current statute, NRS 632.014, the language is under nurse anesthetist practice under the care of a licensed physician or other provider. So we're just using the current statutory language, and my co-presenters may have more to say on that.
Thank you, Senator Buck, for the question. Miranda Hoover for the record. So we put into the bill under a patient must be under the care of a licensed physician, dentist, etc., because of the way facilities across the state all work in different care teams, as previously mentioned. So this allows for CRNAs that are, especially in the rural areas, that really are not working in tandem with an anesthesiologist per se, but also for CRNAs that work in that direct care model team in more of the urban areas to continue to do their jobs. And I'll pass it on over to Art, if you'd like to say anything else.
No, I will.
Okay.
Arthur Savanak for the record. Again, I just wanted to say thank you. I appreciate the opportunity you've provided us today. I just wanted to, one statement has stuck in my mind, and a statement from Dr. Metzamore that I would like to refute, that he said accepting a lesser standard of care from CRNAs is both insulting and incorrect, and I just wanted to clarify that. I have provided anesthesia care to anesthesiologists, surgeons, CRNAs, their families, generals, admirals, corporals, sergeants, and captains, and they all are provided the same level of high-quality care with the same high-quality outcome. And I just wanted to clarify that statement, please. Thank you.
Thank you.
And if I may, Madam Vice Chair, I'm hoping that Miranda Hoover for the record, I'm hoping that answered your question, Senator Buck, but I'm happy to provide additional information if
It sounds like you left it vague so you could cover all your bases.
Correct. And I would like to provide a few closing remarks, Madam Vice Chair, if I may. So again, Miranda Hoover for the record. So really three things. First is, and I appreciate Mr. Hillerby coming up here, as yes, this bill does not seek independent practice for CRNAs. It is simply to clarify the language that CRNAs already have for scope of practice. Secondarily to that, yes, we all know healthcare and healthcare policy can be very muddy and very confusing and a lot of weird conceptions, and we are not here today to change CMS regulations or opt out. That is not what we are seeking, and that simply muddies the water on this conversation. And third of all, one thing that we did not mention during our testimony, but I think is very relevant, is the School of Medicine down at UNLV is going to be starting a CRNA school, the first CRNA school in the state of Nevada. And without this bill, without AB 198, there really is no point for there to be a CRNA school starting in Nevada, which will, of course, recruit and retain CRNAs here in the state. And so this bill helps to support the endeavors of the UNLV School of Medicine to start the CRNA school so that we can tell those students when they come in, so that when they go for tours, looking at all the schools that they have the ability to go to, that Nevada truly does care about CRNAs and allows them to practice within their scope. And so that's, again, what we're here asking to do, and we appreciate your time, and thank you very much.
Thank you, Assemblyman.
Thank you, Vice Chair and members. David Orient-Licker for the record. I'd just like to first echo this point about this changing this, passing this law will help us attract and retain certified nurse anesthetists who can go to other states that have this kind of authority for them and allow them to practice within the full scope of their authority. The other thing I'd like to say is I spent 6.5 years at the American Medical Association dealing with ethical and legal affairs. And while I'm proud of a lot of things the AMA did, I also know that when it comes to scope of authority issues, the AMA has a history of erring too much on limiting authority of competitors under the guise of safety concerns. They've defended a lot of lawsuits, been under Federal Trade Commission orders, and I think we sometimes err on the side too much of preventing legitimate competition by alternative providers, and I hope we don't do that with this bill. Thank you.
Thank you so much. And with that, I'll close the hearing on Assembly Bill 198. And I will open it up for public comment. Is there anyone in Carson City wishing to give public comment? Seeing no one in Carson City, BPS, is there anyone on the phones wishing to give public comment?
If you would like to provide public comment, please press star 9 now to take your place in the queue or raise your hand in the Zoom window. The public line is open and working. There are no callers at this time.
Okay, thank you so much. And with that, that concludes our meeting for today. Our next meeting will be Monday, May 15th at 8 a.m. And we'll see you all there. Have a great and restful weekend.